Here we go. Now we're recording. Okay, let's reshare. All right, so when we talk about our urinary system, we're talking about our kidneys, our ureters, and our bladder. So typically most people have two kidneys, right? So two bean-shaped organs that are, located in your abdomen area. They're the size of a fist, and usually they're just below the rib cage, one on each side of the spine. Every day, our kidneys will filter about 120 to 150 quarts of blood, and this will help produce 1 to 2 quarts of urine. Some of the other parts of our urinary system are the ureters. So the ureters are thin tubes of muscle, one on each side of the bladder, that carry urine away from each kidney to the bladder. So if you can picture your two kidneys, then they have the two, small tubes coming out of them, that's the ureters, and then both of those tubes go right into the bladder. So the bladder is the last thing there. So the bladder is located in your pelvis between your pelvic bones. It's a hollow muscular balloon-shaped organ, and it expands as it fills with urine. So a person does not control kidney function, but they do control bladder function. The bladder stores urine until a person finds an appropriate time and place to urinate. And unfortunately, some people have issues with that, and some people don't have as much control. So let's talk about that just a second. So, the whole process of urinating. So a normal bladder is going to just, collect all of this urine. It can hold about 1.5 to 2 cups of urine. So how often a person will urinate depends on how quickly the kidneys produce urine that fills the bladder. So we have muscles of the bladder that remain relaxed while the bladder fills with urine. As it fills to capacity, there are signals sent to the brain to tell the person that they need to urinate. During urination, the bladder empties through the urethra, which that's another part of our urinary tract, and that's located at the bottom of the bladder. So we have 3 sets of muscles that work together almost like a dam to keep the urine in the bladder between trips to the bathroom. So the first set of muscles is the urethra itself. So the area where the urethra joins the bladder neck is composed of a second set of muscles known as the internal sphincter. So the urethra is the first part, the internal sphincter is the second part. This helps urine stay in the bladder. Then you have a third set of muscles, and this is your pelvic floor muscles. So this has to do with your external sphincter. And this surrounds and supports the urethra. So to urinate, the brain signals the sphincters to relax. And then as the sphincters relax, urine exits the bladder through the urethra. And then I just have one more thing I want to tell you before we get into the PowerPoint here. So as far as our urinary system goes, if you're thinking about what goes on inside of the kidneys, there's a couple of things I need to tell you about. So we have something called nephrons. So nephrons, there's a ton of them all inside of our kidneys, millions. So they receive fresh blood from the heart via the afferent arteriole. So this blood comes from the heart through this arteriole to those kidneys through the nephrons. So each nephron has a couple of different parts to it. One part is called the renal corpuscle. So the renal corpuscle, it's supposed to function as filtering blood and creating urine. So inside the renal corpuscle, there's something called a glomerulus and a Bowman's capsule. Then we also have another part to the nephron called the renal tubule. The function of this is to reabsorb and secrete substances in or out of the filtrate. So part of that renal tubule is your proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting tubule. So let me see if I can show you a picture real quick. Stop sharing this just a second. This is kind of hard to see. Hopefully you can see this okay. So if you can kind of picture inside your kidney, this is kind of what a nephron looks like inside. So remember, here's the Bowman's capsule and your glomerulus up here. And then over on the right-hand side, this is where the renal tubule is. So remember, here's all parts of the renal tubule. So proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then collecting tubule. So it's in this second part is where we have, like urine's pretty much already made, but in this part is where the body decides like, oh, I need to keep a little bit more potassium in here, or I need to get rid of some of the sodium or whatever. So it will like keep a hold of certain things that it thinks your body needs, and it'll get rid of other things that it thinks you don't need. So it kind of picks and chooses what goes into the urine right there. So I just want to show you that picture so you can kind of get an idea of what I'm talking about. All right, so then we can get into this now. So in this PowerPoint, we start to talk about things like acute kidney injury and chronic kidney injury or chronic kidney disease. So when we start talking about those things, you need to start thinking about what the kidneys do. Because once you know those functions of the kidney, it makes more sense to see what happens when it doesn't work right. All right, so what the kidneys do are these things here that I have on this slide. So your kidneys will help get rid of your metabolic wastes in your body. So they regulate fluid volume, they regulate composition of electrolytes, they assist in maintaining acid-base balance, they actually help regulate your blood pressure. Your red blood cells are made here, and you also have calcium absorption, or metabolism, excuse me. So it does quite a few things here if you think about it. So with that calcium metabolism, it helps activate vitamin D, which allows absorption from the GI tract. And then when we talked about this red blood cell production, inside your kidneys, your red blood cells are regulated by synthesis of erythropoietin. And so I'm sure you guys have heard of that, at least I hope you've heard of that. So this is a medicine that sometimes people will get in dialysis. They get erythropoietin because they're having a hard time with this red blood cell production. So typically when someone has kidney disease, they don't make a whole lot of red blood cells.
I think we lost you again. Anybody else hear her?
I can hear you fine.
Yeah, I can hear you fine. I can hear you fine.
Okay, I was gonna say there should be no reason you can't hear me. I'm not doing anything different.
I lost my signal, sorry. The storm.
Well, yeah, there's a big storm outside, so I might lose power.
Yeah, that's okay. Just do the best you can. This is being recorded, so. So anyway, Ashley, you can feel free to jump in because I know you have a lot of experience with renal stuff. So if I'm saying anything incorrectly, you correct me. All right, so anyway, what I was saying is a lot of times when people have kidney issues, they'll have a hard time producing red blood cells. So they'll be anemic, you know? So you'll typically see them get erythropoietin as a medication that they get to try and help, you know, boost their red blood cell production. All right, and then again, this just says role of the kidneys. It filters the blood, which creates that filtrate called the urine. And, you know, we just talked about what all of that does. And I already told you how this works, so I'm not going to go through that again. And here's that picture that I tried to show you before. Okay, so the next part of this is just kind of talking about some different terms that are pretty important when you're talking about the kidneys. So one of those things is creatinine. So creatinine is a waste product from muscle breakdown. So it's solely filtered from the bloodstream via the glomerulus, and it's not reabsorbed or secreted within the nephron. So this is like a really good way of telling if someone's kidneys aren't working really well, that creatinine level. So a normal creatinine level is 0.6 to 1.2. So usually when someone has kidneys that aren't working very well, their creatinine level is going to be elevated. It's going to be, you know, high. So this will increase in the body when the kidneys aren't filtering really good. Another thing they talk about on this slide is creatinine clearance. So a lot of times physicians will specifically look at creatinine clearance to decide if a medication is going to be appropriate for a patient or not, especially if they have kidney issues in the past. So if their creatinine clearance is not good, then maybe they'll decide to, you know, do something else instead. So all this is the amount of blood the kidneys can make per minute that is free of creatinine. So, and here's, you know, normal levels for female and males here. Okay, on this slide, it's talking about glomerular filtration rate. This is another important thing that you need to know when you're talking about the kidneys. So this is the rate of blood flow through the kidneys, and it shows how well the glomerulus is filtering the blood. So like when you have really good kidney function, your GFR, or your glomerular filtration rate, is going to be high. So like, you know, if I'm between 90 and 100, I'm doing really good. My kidneys are working great. But if I'm between, you know, 20 and 30, then my kidneys are pretty damaged and they're not working as well as they should. So a normal GFR in adults is 90 or higher. And so remember, this is going to depend on how old the person is, their weight, their creatinine, their sex, and their race. So a normal GFR, if you have that, you're going to have pretty much normal urine output. Your BUN and creatinine are probably going to look pretty good, and your electrolyte and water balance are going to look pretty good as well. So when people aren't filtering really well, if they're having an issue with their kidneys, then you're going to see this level decrease. So remember, when we talked about creatinine, that's going to increase, but the GFR will decrease, and that's going to show that they're not filtering things right. So the other thing on here is talking about BUN, so the blood urea nitrogen. So this measures the blood urea nitrogen, and it's a waste product from protein breakdown in the liver. So it's secreted in the blood and filtered out through the kidneys. So a normal level is 6 to 20. So typically, if someone's kidneys aren't working real well, then that's going to be elevated. So it'll be higher. Let's see if I have it on here. Okay. Okay, so this is where we get into acute kidney injury. So acute kidney injury is a sudden decrease in renal function that will lead to a buildup of waste in your blood, fluid overload, and electrolyte imbalances. The thing to remember about this is that it can be reversible. So even though you're having an issue, you can fix it, and your kidneys can get better. So that's kind of what's a little bit different about this compared to chronic. Now, how do you know when someone has an acute kidney injury? Well, typically you'll see this all the time in the hospital setting. So someone will have maybe a decreased urine output, and they'll show all their labs will be messed up. Like their creatinine will be up, their BUN will be up, their GFR will be down. Like these things will start showing. So you're noticing this as a practitioner and you're like, okay, what's going on here? What do I need to do for this person? So that's kind of what we're talking about here. So this is kind of an important part of acute kidney injury. There's 3 causes. There's pre-renal, intrarenal, and post-renal. So pre-renal is the one we're going to talk about first. So what this means is that if you have this cause, it's because you have decreased blood flow to the kidneys. So this is this one occurs the most often. About 60 to 70% of cases are pre-renal. So when you talk about this, some of the possibilities of things that could cause you to have decreased blood flow to your kidney would be things like a GI bleed, hypotension, sepsis, shock, renal artery stenosis. So anything like that that would cause you to not have really good blood flow going anywhere, that's going to make you have this. Now, on the slide here, let me see if I have anything else that I didn't say. You know, other causes, like anytime you have like a massive internal bleed somewhere, that would cause this, you know. Dehydration, burns, you know, anything like that, that would cause this. So then when we talk about intrarenal is going to be caused by actual damage to the kidney itself. So remember, pre-renal was not enough blood flow to the kidney. Intrarenal is you actually have physical damage to that kidney now. So this physical damage to the kidney could be from an injury, like, you know, maybe some kind of traumatic injury, like someone stabbed you in the kidney, or you got shot through your kidney or something like that. Or it could be something like a chemical injury. So when we talk chemical injury, we're talking about things like medications. So antibiotics and contrast dye and things of that sort. So when we talk about antibiotics that can affect your kidneys in a bad way, we're specifically talking about aminoglycosides. So this is things like gentamicin, that type of stuff. Myosin is the ending for those aminoglycosides. So those you really want to watch out for. It doesn't mean that you can't give them to people, like you still can, but you have to be really careful, especially if someone already has a history of problems with their kidneys. And then a lot of people can't tolerate contrast dye. And contrast dye, the reason for that is it will affect your kidneys. So that would be another reason. And then a third reason for intrarenal could be immunologic injury. So maybe you had just a really bad infection of some sort, or you had, there's something that we're going to talk about called acute glomerulonephritis. If you had that, that could cause this. So really, physical injury, chemical injury, immunologic injury, all can cause intrarenal damage to the kidney itself. So that's kind of what you're thinking about here. All right, and then we said the third thing was post-renal injury. So post-renal injury means that there's something that happened after the kidney. So there's a blockage of urine after the kidney somewhere. So maybe in the ureters or something like that. So typically, it's going to be things like kidney stones. It could be a stricture. You know how a stricture just means that, you think about your ureters, it's just this long tube. So maybe the diameter of that is restricted in some way. It's constricted somewhere. It could be from blood clots. It could be from BPH. It could be from a malignancy. It also could be from pregnancy. Another thing too that I have written down is spinal cord disease or injury could also cause this. So the thing with this is, as you have this blockage of urine there, pressure rises in your kidney tubules and it eventually causes a problem with your GFR. Your GFR is going to decrease. All right, before we go on, I just want to give you a couple of terms that I want you to write down and make sure you're aware of and know what I'm talking about. So have you guys heard of the term azotemia?
I have not.
Okay, so write this down. Azotemia means abnormally high levels of BUN and creatinine. And azotemia would mean that the BUN and creatinine is high in the blood specifically. And then what does oliguria mean?
Lack of urination?
Kind of, but not completely correct.
Is that like a slow flow of urination?
Yeah, so it's a decreased urine output. So you're going to have either 80 milliliters per day, but less than 400 milliliters a day. So anywhere in between there. So anywhere from 80 to 400 milliliters a day. And remember, normal urine output, you would want to see about 30 milliliters an hour. So if we're talking 24 hours, how much should you have per 24 hours?
Around like 720.
Yeah, so you could see this is definitely a decrease, a big decrease in urine output, right? So when you're talking oliguria, that means that this person is not putting out as much as they normally would be. What's anuria?
I think that's without urine.
Yeah, so this could be either no urine at all, or it could be less than 80 milliliters a day. So sometimes people will still put out a teeny bit, but it's just not very much at all. So I just want to make sure I explain what those were real quick before we go on. Okay, so the next part of this talks about stages of acute kidney injury. This can be kind of confusing at times, so just try and stay with me as best you can. Okay, so when we talk about the stages, initiation is the first stage. So if you have this acute kidney injury, this is where it starts at. So there's something that happens to your kidney, and it's one of those things that we just talked about. It could have been that pre-renal, intrarenal, or post-renal thing that happened, and it causes this injury to your kidney. So you start to get some signs and symptoms, like maybe you have the low urine output, some of your lab work starts to get out of whack, things like that. So that's that initiation stage. So usually it lasts from a few hours to several days. So the second stage is the oliguric stage. So in the oliguric stage, urine output will be less than 400 milliliters a day, because remember what I just said that was. Your glomerulus is not filtering the blood properly, so you'll have a decrease in that GFR. Sometimes you'll see, increased BUN and creatinine. You'll see some neuro changes sometimes. Maybe people might get a little confused, itching, that kind of stuff. All right, other things. You could also see an increased potassium, You might hold on to more fluid in your body. You might seem like you have too much fluid on board. Um, you could have metabolic acidosis. And your urine's going to look really concentrated. So typically this stage is going to last about 1 week to 2 weeks. And so this is a worrisome stage of this whole process. So if you don't get this, taken care of and get this treated right here and try and nip it in the butt, then this can get a lot worse. So this stage, you want to make it as short as possible because it's going to, the longer someone's in this stage, the more of a risk they're going to have a long-term problem with their kidneys. Okay, so we want to try and get them out of this as soon as possible. All right, and then on here, I kind of tell you a little bit about like some things they might do for treatment, because really it depends on which stage of this acute kidney injury you're in and how they're going to treat you. Because you can treat people differently depending on which stage they're in, because they have different things going on. So again, in this stage, we said, sometimes your electrolytes are all out of whack. So of course they're going to treat all of that. But remember we said that you have too much fluid on board and your urine looks super concentrated. So sometimes they may even do like a dialysis with you at this point, because your blood is just not filtering just right like it should. Your kidneys aren't working like they should. So dialysis would fix this for you, would clean things and put, stuff back in, and you would be better after the dialysis. All right, so the third stage is the diuresis stage. So in this stage, nephrons can't concentrate urine, so water and electrolyte levels will still be not quite right, but now we can filter waste. So urine will be highly concentrated, and it's going to cause you to have this osmotic diuresis. So now you're going to have increased amounts of urine, and like we're talking a lot, like 3 to 6 liters a day. Now your urine's going to look really dilute because you're putting out so much. Your BUN and creatinine are going to start to decrease, so they're going to get a little bit better. And then some of your electrolytes still might not be quite right. Like you might get a low potassium now because you have such dilute urine now. You're getting rid of it in your urine. So you may have to treat that. This stage is going to last about 1 week to 3 weeks. And then the last stage is the recovery phase. So this is going to be when your GFR returns to normal, your urine output returns to normal, your BUN and creatinine and your electrolytes, everything starts to get back to normal. This can actually last a year or more, this recovery stage. So it depends on the amount of damage that were done to the kidneys and also the patient's age. And then with these stages, some patients never get to one of these stages. Like it doesn't necessarily go from one to the other constantly. Sometimes people will go right to a different one. Like maybe I don't go into the oliguric phase, but I go right into the diuresis phase. So sometimes it'll be different. So anyway, the whole point in this is, we want to catch this as quick as possible, because the longer someone is in acute kidney injury, the more damage it can cause to the kidney, and then they're going to end up in chronic kidney failure. So super important. So we want to figure out what the cause is of this injury. So remember we were talking about, the pre-renal, intrarenal, or post-renal. So we want to figure out what the cause is, because once we know, we can treat it, and then, it'll fix things. We also want to avoid using nephrotoxic medications. So if necessary, we want to use a lower dose and give it sparingly. We want to administer IV fluid as a fluid challenge to promote kidney perfusion, or as a fluid replacement if the patient is in the diuresis phase. We also want to administer diuretics to promote increased filtration of the blood by the kidneys. And then for acute kidney injury that's caused by nephrotoxic drugs, sometimes you can actually give calcium channel blockers to prevent the movement of calcium into the kidney cells, and that'll help increase the GFR. So let's talk about this just a second before we move on. So again, you want to figure out what the cause is, because the cause is going to help you fix this. So if you know what the cause is, you fix that, and then that's going to get them out of this acute kidney injury. So it depends on which stage you're in, on how you're going to treat this. So if I'm in the oliguric phase, and I'm not putting out a ton of urine, but I have a lot of fluid on board, what kinds of things do you think they might do for me?
Like diuretics?
Yes. So I just want you to make sure you're thinking, critically think about this on what's going on at each stage, because you're going to be treated differently, right? So whereas if I'm in the diuresis phase, where I'm putting out a ton of urine, maybe I need IV fluids now because, I'm putting out so much urine, now I'm kind of getting dehydrated, right? So it's going to vary depending on what's going on. All right, so then we get to chronic kidney disease. So I have this picture on here of this little old lady. She's got this renal insufficiency. So some of the things that she has going on. So she has the decreased ability to concentrate urine. She may have oliguria. She may have an increased BUN and creatinine. She can have anemia. She may have a high potassium and a high blood pressure. Why would she have a high blood pressure?
Excessive fluid in the body?
Well, let's think about this a minute. So remember at the beginning, we talked about things that the kidneys do for us on a normal basis. They affect our blood pressure, right? So if we have damage to our kidneys at this stage, like we do, then you're going to have not good control of your blood pressure, right? And that's why we also have anemia. Because we said, this is where our red blood cells are made. All right, so what is this? This is a significant decline in kidney function that happens over a long period of time, and it leads to the buildup of waste, water, and electrolyte imbalances in a body, and it's not reversible. So that's like a big difference compared to acute kidney injury. And then I just kind of put here, what happens in chronic kidney disease. So again, in chronic kidney disease, your glomerulus is unable to filter properly, and therefore your glomerular filtration rate is going to be decreased. And now you're just not concentrating urine like you should. So then this gets into a little bit about the GFR. So there's different stages of chronic kidney disease. We've got stage 1 through 5, and then this over here talks about the GFR and where you're at. So if you're stage 1, you're pretty much doing fine with your kidneys. You're, 90 or above with your GFR. I don't know if you guys remember me talking about my mother-in-law occasionally, but my mother-in-law had an episode where she had sepsis, and she got chronic kidney disease as a result of that. During her episode, it was an acute kidney injury that she had going on, right? But they didn't catch it quick enough. You know how I said earlier that if you don't catch it quick enough, you can end up with, permanent damage. Well, that's kind of what happened to her. So as a result of that whole episode, she's in stage 4 kidney disease. So her GFR is between 15 and 29. So just kind of keep that in mind that, you can actually have acute kidney injury and it could progress to this if they don't catch it quick enough and do something fast enough about it. So typically when you get to stage 5, this is when your kidneys fail to, your kidneys aren't working like they should enough at all. So now you need to be on dialysis or something at this point. And usually your GFR is less than 15. Okay, so this is where it gets
Miss
into,
Silk,
yeah.
can you get on dialysis before it gets that far? Like, if you know you're headed in that direction, if you were like at a stage 3 or 4, maybe a 4, would it help to start it early?
No, I don't think they do that. I think they wait till you get to that point.
Till your kidneys are just no good at
Yeah.
all?
Yeah, they try to, they treat your symptoms basically when you have chronic kidney disease, and they try to keep you as healthy as possible for as long as possible, because that's going to prolong you until you get to that point.
Hmm.
So yeah, they don't necessarily make you do dialysis that early.
Okay.
If they do, which they don't, you're right, because it will hurt your kidneys worse. Because then it will get used to the machine doing it. And when we have like acute patients, I had 2 within the last couple months. We're very careful how we pull off fluid, because if we pull off too much, that kidney will get lazy, and then it will set them into chronic failure.
Oh, okay. Thanks, Ash.
You're welcome.
Okay, so in this signs and symptoms part, thank you, Ashley, too. I appreciate you stepping in there.
Sure.
In the signs and symptoms part, the whole thing in the beginning when I told you about the role of the kidney and all these different functions that it serves. So this is where it starts to make sense, and you'll be like, oh, that's why they have this sign and symptom. So, okay, we have this increased waste in the body because we're not filtering right. So we have what they call uremia. So a lot of times when you have that, you'll see people complain of a lot of itching. So they get that pruritus. And sometimes you'll see neuro changes with them where they're a little bit confused. So that's very common. That's part of that uremia. And always think, as a part of not filtering right, you are kind of holding on to fluid in your body because you're not urinating like you should, right? So you're hypervolemic. So you can have things like edema. You can have that hypertension. You can have cardiac problems, all these things. Your electrolytes are going to be all out of whack. So typically you're always going to have a high potassium. You're going to have a low calcium and a high phosphorus if you're chronic kidney. So the high phosphate levels will cause the low calcium levels, and that stimulates that parathyroid gland that we just talked about in the last stuff to produce parathyroid hormone. So this is going to cause your calcium to leak out of your bones and cause bone problems. So you could be at risk for fracture even. So typically when you have a low calcium, you're also going to have a messed up magnesium level too. So the magnesium level is probably going to be high. Now, think about your urine. So we're going to have oliguria now. So depending on how bad your kidney disease is, that could change where to maybe you go to anuria, So it just depends on where you're at in your process there. You could have proteinuria and hematuria. So the glomerulus is damaged, so it's allowing blood cells and proteins to leak through, and you can have lower albumin levels and everything as well, to make that anemia even worse. So that's why we tend to give that erythropoietin medication, especially in dialysis. I used to, send people for that all the time, and they would get it down there. So this is going to help create red blood cells in your bone marrow, and that's going to help with that anemia. Sometimes when people are really bad, I have seen people actually get units of blood when they were down in dialysis as well, because they're so bad with their anemia. Also down here, it's talking about renin. So renin plays a role in increasing your blood pressure. So in chronic kidney disease, that glomerulus is filtering less water, and the kidneys think the blood pressure is low. So it releases renin, and it in turn increases the blood pressure even more. So that's kind of part of the reason why you have that high blood pressure. So people always, any chronic kidney person is always going to be on some kind of blood pressure med, always. So as you see, as we keep talking about these different disorders, there's like a relationship between everything. So high blood pressure, diabetes, very closely related, right? And also with kidney disease as well. All right, so here's some causes of chronic kidney disease. So again, the number one thing is going to be your high blood pressure. So constant high blood pressure is going to cause you to have this problem. Diabetes is another one. So those are the top two there. And then acute kidney injury, like my mother-in-law, that's another cause. Polycystic kidney disease can cause this, which we'll talk about that later. Infection, and then also nephrotoxic drugs. So we mentioned things like aminoglycosides and contrast dye earlier, but there's also like chemotherapy drugs that would fall under this, and then NSAIDs even can fall under this. Okay, so treatment when you have chronic kidney disease, you're treating symptoms, right? So you want to control that blood pressure and their blood sugar as much as possible. So make sure they're on medication for those and keep them good, So typically they're going to have someone on an ACE inhibitor or an ARB. And then we want to monitor that GFR and blood pressure regularly. So we want to make sure people are constantly, going to follow-up appointments to make sure they're doing well. Advanced stages, when you're really advanced in your kidney disease, then you're going to have dialysis, like we talked about. And then also, those people at that stage could also possibly do a kidney transplant if they qualified, but it just depends. And then diet changes are going to be another thing that we do for treatment. So remember when I was talking about how a lot of times these guys have a lot of itching. I don't know if you can see it in this picture very well, but it almost looks like this person has white powder on their skin. This is called uremic frost. So look, I don't know if you could, this is kind of small writing, but so because we hold on to so much of this waste product in our body, it has to come out somewhere. So it comes out through our sweat glands and like in these little crystals, and it looks like this. So some of the things we do for treatment, like how I just said we do some diet changes. So we want these guys on a low protein diet. So urea is a waste product of protein breakdown. So we don't want them to have more, because that's going to cause more issues. So we try to restrict their protein a little bit. And if you've ever tried to call down to dietary and order a tray for someone who is, renal, it's horrible because they are restricted on everything under the sun. And I kind of get it because I would hate that too. But there's a reason for everything they're restricted on. And then we talked about what we do for the anemia. And then sometimes they'll even supplement people with anemia with iron too. So you could see them possibly get iron infusions or something like that. All right, and then with their electrolytes, we're going to try and fix their electrolytes as much as possible. So for the hyperkalemia, if there's someone who goes to dialysis, that's going to fix the hyperkalemia. So you wouldn't necessarily have to do anything with that. But we want to restrict potassium-rich foods because they're already high there, so we don't want to make that any worse. So I listed some things here that are high in potassium that maybe you would want to, watch. This person should be on a cardiac monitor because anyone who has a high potassium also has, risk for some cardiac things going on. If they were really high and we needed to get things down, we could give them Kayexalate, right? So Kayexalate is that brown liquid that you either get them to drink orally or you could even give it rectally if you had to. It's crazy. That stuff will make you have a bowel movement and you'll get the potassium out with that. So then we talked about the high phosphorus that they have. So because they have high phosphorus, they have low calcium, right? So this is where that one medication comes into play. So I don't know if you remember us talking about that before, but there's something called Foslo or calcium acetate. This is a medicine, they're big, they're like real big capsules. So they take this medicine with every time they eat, basically, they take this. And it binds to the phosphorus in their system and kind of gets that out of their body so they can use what little calcium they do have. So that's kind of the purpose of that. And then we talked about they can have high magnesium. So that would be another thing you would want to make sure you watch these things for that. And then, of course, dialysis would be the next step here, right? So if we are stage 5 kidney disease, we're going to have this dialysis. So what dialysis is it's a way that we can help sustain life for people who are really having a hard time with their kidneys at this point. So what it does is it helps to get rid of excess fluid and electrolytes from our body. It will help with that acid-base problem that we're having. It gets rid of the waste products, and it restores an internal homeostasis with our fluid balance. So hemodialysis will shunt blood from the body through this dialyzer and back into the circulation. So to do this, you have to have vascular access. So I don't know how many of you have taken care of a renal patient before, but typically they have what they call a fistula. And usually it's in their upper arm somewhere. And then sometimes you'll meet someone who's had so many different sites that have gone bad that sometimes they'll have it in a different place that's weird because they've ran out of spots,
I think I have a patient that has one in their leg, in their thigh.
Yeah, in their groin.
Yep.
So
Okay.
chances are they probably had it, in their arms before, but now they're running out of spots, so they had to stick it there. So Ashley, can you tell us what a fistula is?
A fistula is, so they take, their veins in another sense, but it's not like a graft and fistula. So a graft would be part of your vein and an artificial connected. And then a fistula would be like theirs, but it would be a stronger, they have to go in, I want to say, like open it up, balloon it a little bit when they're surgically placing it. So it's up closer to the, it's bigger and it's up closer to the surface of the skin. And it can hold the pressure coming in and out because our regular veins can't hold that pressure.
Okay.
Yeah, they create like a super vein.
Yeah, it looks like really big and thick compared to a regular vein, right? And so usually if you're looking at your patient, you'd be able to pick it out no problem because it's different looking, right? And so basically they connect an artery and a vein together. And so the circulation is going to be different there right now. So when they go to do dialysis, they have these ports there that they hook up the machine to. So basically they're taking blood out of this person's body. The blood's going into the dialysis machine. It's getting cleaned to get rid of all of those waste products. And then it comes back into the body through the other side. So for you as a nurse, you always have to assess that site. So the things that we look for is the bruit and the thrill, right? What's the bruit?
That's like the whooshing sound of the fluid running through it.
Yes. So we want to hear that because that means that we have good flow through there. We have, good blood flow. There's nothing wrong there. If we didn't hear a good sound, that's indicating that there might be a problem with the site. And if there's a problem with the site, you can't do dialysis, you need to do a different way. So that's a big deal. So that's the bruit. And what's the thrill?
Feel? Do you feel it?
Yeah, you have to feel it. So you could actually put your fingers on that site and you would feel like, I don't know how to explain what it feels like. What do you guys think?
It's like a pulsating, like there's an alien living inside.
Yeah, kind of like that. So you want to make sure that you're getting good blood flow through here. So this is something that you should check every shift frequently. And you should even teach your patient, who is that dialysis patient, to do that as well. So teach them to feel it, make sure they feel a good, good thrill there. So with the Brewie, with the sound, you're going to use your stethoscope and put your stethoscope there and hear it. But with the thrill, it's just your fingers. You'll put your fingers there. Okay, so some reasons why someone might need dialysis. So there's quite a few different reasons here. So not only just because they have chronic kidney disease, but also maybe they had acute kidney injury. Like when my mother-in-law had that issue going on, she had an episode of dialysis. So they had a temporary port that they put in her to have that happen. Sometimes it's because of a drug overdose. Maybe someone, took something really awful that they just need to get out of their system quickly. So they do dialysis to get it out. A couple other things I have mentioned here: renal insufficiency, persistent high potassium. Like maybe you've done everything under the sun to get this person's potassium down, but it still isn't working. It's still really high. So they would go to this. Also, hypervolemia that doesn't respond to diuretics. So someone has too much fluid on board and you've done your Lasix and you've done all these things and it just isn't taking it off, then this might be the thing to do. Okay, so some of this stuff isn't really as important. I'm just going to try and get through this pretty quickly here. So before dialysis, if you send someone to dialysis, like you're working on a floor and you go to send them, you want to make sure you assess their vascular access to make sure it's working good. You want to get, a set of vitals. You also want to make sure that you get a weight. Look at their labs for the morning, make sure all of that's done. And then if there's any medications that they would be due for that morning, you want to make sure that you're not going to give them something that's going to dialyze out. So if you ever are unsure, you need to call and ask. So usually there's certain things that you can just wait to give until they get back. All right, during dialysis, like if you worked in dialysis, which Ashley could chime in here, there's certain things that you would want to be doing while you're working down there. So you're going to monitor for complications. So like you can have clotting that goes on in that dialysis circuit, where they're taking the blood out and cleaning it. So you would want to watch that. You would want to watch the temperature of the dialysate, and then the regulation of the ultrafiltration as well. Again, we're going to monitor their vitals and their coag studies. So they're going to actually monitor how their blood is clotting. So typically they give heparin while they're down there because they don't want things to clot off as they're trying to, clean everything. So heparin is given, so you're going to want to monitor all of that stuff. And because heparin is given, you also want to make sure you have the antidote for that, just in case. So what's our antidote for heparin? Protamine sulfate, right?
We don't
So
have
you would want to make sure that you have that on hand just in case you needed it. All right, and then there's a couple other things I have listed here. So advise the patient to notify you if they have a headache, nausea, or dizziness during the dialysis. And then usually they don't eat during dialysis as well. When they come back after dialysis, when they come back to your floor, again, you're going to monitor your vital signs and look at your labs. Usually you compare the pre-procedure weight to the post-procedure weight. You assess for any kind of complications, because if you think about it, you're taking off a lot of fluid, so this person could end up having some hypotension. So that could be a problem, And then some of the other stuff here: assess for signs of hypovolemia, assess for disequilibrium syndrome, and then avoid any kind of invasive procedures for 4 to 6 hours after dialysis, because you're at increased risk for bleeding because you just had heparin, Ashley, have you seen disequilibrium syndrome before?
Yeah, I just want to say about the heparin. We don't have the how do you say that?
Protamine sulfate.
Yeah, so what we have a different, this is where I got screwed up in pharmacology, because we have a different type than what were taught in like farm, and it wears off quick. So
Okay.
you got to give it to the patient at least 1 hour before treatment is up, because by the time that 1 hour, it will be dialyzed out. And if you give it to them within an hour or less, they can bleed forever.
Okay.
That makes sense.
Can you tell them what disequilibrium syndrome is?
When they're, do you mean when they're like blood pressure and everything, they get confused, disoriented, stuff like that?
Yeah, there's a specific syndrome that people can have, especially if they're new to dialysis or if they're like an older adult, they might be more at risk for this. Sometimes they can have seizures with it, stuff like that. Have you ever seen that?
I've never seen seizures, but we monitor so much. Like
Yeah.
this is saying. So it goes like, we have to look at the calcium baths. We have to look at the bicarbonate. Everything has to like match up and watch everything. So I don't even know how to describe it because there's so much.
Okay, so there, when you guys do your reading in your ATI book, there's a section about this. So make sure you take a look at that, because that is something that you could possibly see. So not everyone is at risk for it, but it's a complication that could happen. So they basically just say, you know, make sure the patient tells you if they're having these symptoms. And if they do have this, you may have to slow down the dialysis exchange rate, is all they're saying. And then like if they would have, you know, seizures or something as a result, you would give them medications to quit their seizures. You know, you just treat symptoms basically. Let's see, what else? Oh, another thing I just wanted to mention on this slide here. So up at the top right, this is talking about looking at the access site. So sometimes people are kind of a bleeder afterwards. So you want to monitor the access site for any kind of drainage or bleeding. So they say do not compress the access site. Light pressure is okay for bleeding. So you don't want to put like extreme pressure there, because you can mess up the fistula, you know. You don't want to mess up their site, but you want them to quit bleeding. So if you put light pressure there for a little bit and it's still bleeding and you can't get it to stop, they need to go, you know, to the ER or something to get it to quit. So that's what we need to make sure we're telling people. Okay, so then this mentions peritoneal dialysis. This is something that you're not going to see a ton of, but you'll see it occasionally. So this is where there is a hypertonic dialysate solution that's instilled into the person's peritoneal cavity. And the person's peritoneal cavity is kind of their reservoir for getting rid of these waste products. So what happens is you instill all of this fluid into the cavity, and it sits there for a period of time. You know, your physician would designate how long that is. And then once it gets drained out, you know, after that period of time is up, you drain all that fluid out, and that kind of gets rid of some of those waste products. So there's some kind of like osmosis that happens inside the peritoneal cavity where all of those waste products kind of go into that solution. And then when you get rid of the fluid out of your body, it goes out that way. So it's kind of weird, but that's how that works. So in order to be able to do this, the person has to have an intact peritoneal membrane without adhesions from infection or multiple surgeries. So I know there's a ton of people that have had lots of abdominal surgeries where they get adhesions and stuff. So, you know, you can't necessarily do this if that's the case. And then this talks about who would be a good, I'm not going to go through all of this because we don't have a whole lot of time here. But basically, not everyone would be a good candidate for this. You have to be able to follow directions, and you have to be real sterile. Like, it's kind of a sterile procedure here. You don't want to like not do the steps the right way. Let's put it that way. A friend of mine, her dad was put on this, and he's in his 80s, and he was like, "Oh, I feel too full from this dialysis. I don't think I'm going to put all of it in this time. I'm just going to put a certain amount in." So he put in only whatever he wanted, and then he would get rid of it when he wanted to, right? So he didn't do the right things. So he constantly would have problems with it. And so now he can't do peritoneal dialysis anymore because he wasn't following directions the right way. All right, so anyway, you guys can read through this about the peritoneal dialysis. It's kind of interesting. So one thing I do want to say is this fluid that this dialysate fluid, you have to monitor their glucose with this because it does have some dextrose in it. So that's something that you do need to watch when they do peritoneal dialysis. Other things you need to watch for is there's an access site on their peritoneum. And so you want to watch that for signs of infection. You want to make sure the dressing isn't wet or anything weird like that, because you can get infected pretty easily here. After the procedure is done, you're going to weigh yourself and check your glucose. And then you would take your medications like normal and all that good stuff. Here's some of the common complications that you could have with peritoneal dialysis. So peritonitis. So do you guys remember what that is from Adult 1?
Oh, I remember. I just can't remember.
You remember, but you can't remember. Okay, so remember, this is in the peritoneal cavity that we're talking, that all this fluid is going to go into. So if you have peritonitis, this means you have an infection in that peritoneal cavity, right? All right, so that's something you'd watch for. You could have just a basic little infection at the site. You could have protein loss through, some of this dialysate. You can have high blood sugars and also high lipid levels. And then there is something known as poor dialysate inflow and outflow, because basically you want to put in a certain amount of fluid and have it dwell for a certain period of time. And then when you get rid of it and get it out of your system, you want to have the same amount that comes out. So if you're not getting enough out, that's a problem. So you would need to let someone know that. All right, and then this last part just talks about kidney transplant a little bit. So this would be an option for someone who's end-stage kidney disease. And dialysis is difficult for people. Not everyone can handle that. So typically people seek this out because they want a better quality of life, a lower risk of death, and fewer dietary restrictions, and a little bit lower treatment costs eventually. So things that can prevent you from being eligible for a kidney transplant would be things like advanced age. So if I'm 90 and I want a kidney transplant, I'm probably not going to get one. Severe heart disease, active or recently treated cancer. Maybe I just got over breast cancer, but they don't want to give me a kidney because I just got over that, Poorly controlled mental illness, dementia, alcohol or drug use. Those would be some of the things that would prevent you from getting a kidney. All right, so on here, it talks about you can get a kidney from a living person, a related donor with matching tissue type would give you the greatest chance of survival. So that would be a good thing. So with surgery, typically you do pre-op labs for this person, and then they're given a bunch of medications even before the surgery. So even like prophylactic antibiotics, some things to help with inflammation. They give them immunosuppressants even beforehand, and just a ton of stuff. So they also get dialysis within 24 hours of surgery, and then blood from the live kidney donor is often transfused as well before the surgery to increase the chance of graft survival. All right. So during the procedure, this isn't that important, but obviously during the surgery, you would want to pad bony prominences, communicate to the family frequently because it's going to be a long surgery, all that kind of stuff. But then this is the more important thing here afterwards. So things you're going to watch for. You want to really assess this urine output closely. It should be at least 30 milliliters an hour or more. You want to assess for an abrupt decrease in output because that could indicate rejection. You want to assess the color and odor of the urine hourly. And initially, it's going to look pink and bloody, but then it should start gradually returning to clear. So you need to watch for those things. Assess the surgical site for bloody drainage that may indicate hemorrhage or hematoma, and monitor for excessive diuresis, which could lead to hypovolemia, hypotension, and reduced blood flow to the graft. This person needs to know that they have to be on a specific kind of diet. They need to constantly be on their immunosuppressant drugs for the rest of their life. That's not something they can stop. And then they have to avoid contact sports that can cause injury to the transplanted kidney. So if they were a football player before, maybe now they can't do that anymore. And then with organ rejection, there's different types, and this is all talked about in your ATI book, but there's hyperacute, which would occur 48 hours after the surgery. You can have things like fever, hypertension, pain at the transplant site. And if this is what happened, then they would have to immediately just take it right back out. Wouldn't that be horrible? You wait like 14 years for a kidney and then you have this rejection happen and you get it taken right back out.
It's very sad.
Be awful. And then there's an acute type of rejection. This would occur 1 week to 2 years after the surgery. So with this, you see stuff like oliguria, anuria, low-grade fever, hypertension, lethargy, azotemia, fluid retention. And then this one, they would probably just increase the doses of your immunosuppressant drugs. And then chronic is going to occur gradually over months to years. So Ashley, do you know how long a kidney is good for?
It depends on, really, it depends on they're compliant or not. So we just actually, over the last like 16 and a half years, I've only seen probably less than 10 transplants. And we just had one last week. And so I have had people have their kidney for 20 plus years.
Okay.
Or 5 or 1 or 2. It just depends on how compliant, and a lot of them, if they'll get a transplant, they kind of slack off and go back to their old ways and kind of forget how they got there and begin with, and then it fails again.
Okay. So with this chronic, then this is where you have the gradual return of the azotemia, fluid retention, electrolyte imbalance, and fatigue. And so this would be, hey, I'm just going to monitor the kidney status until dialysis is required. So that's then that's where Ashley would come in. Okay, so other complications of kidney transplants, you could get an infection there, you could get a blood clot, renal artery stenosis, and also ischemia as well. So those would be things to watch for with that. Okay, real quick, I'm just going to go over the kidney stone thing real quick because it's real short. And then I'll leave it at that and we'll get off here after that. But the last stuff that we would go through, I'll either go through it next week with us, or maybe I might record it or something and just stick it on here because we just don't have enough time. All right, so this will be fast. Okay, so with renal calculi, this just is talking about kidney stones. So you guys know from doing that case study thing for this week that, you know, it's also called urolithiasis. Whoops, sorry, I didn't mean to get out of there. There we go. Okay, so urolithiasis is just the presence of these stones in the urinary tract. The majority of stones are composed of calcium oxalate or calcium phosphate. They can also contain other things like uric acid or struvite or cysteine. Reoccurrence of kidney stones is increased in people who have a family history of it or whose first occurrence was before age 25. And I thought this picture was kind of cool. These are actual kidney stones. They are hard and soluble crystallized minerals and salts that have formed out of the filtrate produced by the nephron. So your kidney is essentially filtering urine, but it if it sits for a certain period of time, over time you have these crystals that form and they can get big like this. Some of them are really tiny, some of them get really big. All right, so we have an increased risk in males. You can have the tract of the urinary lining, it can be damaged from this, and you could see why, because they're just the way they're made, they can like rub against things and cause all kinds of damage. A lot of time urine flow can be decreased, and then you can have metabolic defects. You can have urinary stasis or urinary retention that can cause urinary infections. And then decreased fluid intake and increased incidence of dehydration also would cause this. You know, if you're someone who doesn't take in enough liquids, that, you know, you'd be at risk for this. My sister-in-law who has muscular dystrophy, she is at risk for kidney stones, and I think she's had them before. All right, so these can vary in size. They can be really small or they can be really big, almost like a walnut. They're composed of various materials and they're different types of stones, like we were saying. The thing with these is they're not always just in your kidney, they can move. So they can migrate through the urinary system and they can grow and cause a blockage of urine. So most stones tend to form within the kidney, but they can form anywhere throughout the urinary system. So sometimes you'll see them in the ureters or even in the bladder. So most stones can be passed, but it is painful to pass a stone. Usually they're able to pass them if they're less than 5 millimeters. But if they're bigger than this, sometimes they have to do other things. So where can they be located at? So again, anywhere. So in the kidney, the ureters, or the bladder. So for stones to form, there has to be a concentration of minerals and salts in the filtrate. This is going to allow that crystallization of the minerals. So when a crystal forms, it can grow over time and break off and travel throughout the urinary system and cause you all kinds of trouble. Again, here are those different types. So the first one is calcium oxalate. So calcium oxalate is one of the most common kinds. They tend to form in really acidic urine. So this type of stone is composed of calcium and oxalate, and it forms when there's a high concentration of those in the filtrate. So things that can increase the amount of calcium in your filtrate could be, hey, you just have hypercalcemia. You know, if you have too much calcium in your body, it can happen. If you have hyperparathyroidism, that could also cause this. So things that can increase the amount of oxalate in the filtrate would be you eat too many foods that are high in oxalate, or you have a GI disorder like a Crohn's disease or an ulcerative colitis because you can't absorb things very well. So those could be some of the reasons for that. All right, so I just want to mention a couple of foods that are high in oxalate because maybe you don't know what the heck that is. So black tea, spinach, beets, Swiss chard, chocolate, and peanuts. Those would be things that are high in oxalate. All right, down here at the bottom, it talks about also calcium phosphate. So these types of stones form an alkaline urine, and they can happen when the renal tubule issues are present. So this is probably one of the most common types of stones as well. So both of these two would be common. All right, with uric acid. So remember when we talked about gout back in adult 1. So uric acid forms when there's too much uric acid. You have this acidic urine, you can't filter your urine right, so you have too much uric acid in there. So this can cause you to have a uric acid type of kidney stone. Also, if you eat a diet high in purine, if you're really dehydrated, if you have gout, or maybe you have a metabolic problem like diabetes type 2, you would be more at risk for this. So remember, things that are high in purine would be things like poultry, fish, gravies, red wine, sardines, and organ meats. And so I don't know if you guys remember back when we talked about gout, but do you remember the medication that we gave for it? So allopurinol was one of the medications that we gave for it. So that could be something you could actually give for this type of kidney stone, and that would help. All right, cysteine is another type of stone. This one is going to form when there's too much amino acids in the urine. So you would want to limit animal protein intake. Believe it or not, the medication captopril is something that they could give to lower urine cysteine. So you might see people taking that. Let's see. And then I think there's struvite is next. Struvite is a stone that's rare. Usually it forms due to chronic urinary tract infections. So if you have a patient maybe who has a chronic catheter, or they constantly cath themselves all the time and they have all kinds of infections, they would be at risk for struvite, kidney stone. So this one, you want to avoid high phosphate foods. So especially things like dairy products, red and organ meats, and whole grains. So those would be kind of some of the things you'd watch for with that. Signs and symptoms of kidney stones. This is something I want you to pay attention to. So the pain is going to be different depending on where the stone is at. If we say renal colic, this means that the stone is in the renal pelvis. So you're going to have a dull, deep aching flank or costovertebral angle pain. The costovertebral angle is right where this picture is showing it at. So here's your spine. It's right in between kind of your shoulder blades, right in the middle there. If you have ureteral colic, this means that it's in your ureter. So now you're going to have intense, sharp, radiating pain because now it's really causing you all kinds of trouble being in the ureter. You could also see blood in the urine sometimes because of that stone scraping the sides of the ureter as it's moving. Sometimes people have nausea and vomiting associated with this. It's not uncommon to have things like fever and, odorous urine and stuff. Urinary retention is very common with this. And then sometimes people don't have any symptoms. So you may not have any of that until it actually moves and causes you more problems. Okay, so to diagnose this, we are going to look at urinalysis, a 24-hour urine. They're probably going to do an ultrasound of your kidneys. A KUB is an X-ray of the kidneys, ureters, and bladder, so that might be beneficial here. And then there's something called an IVP, which is intravenous pyelogram. This is something that they would do that has a special dye that has iodine in it, that if you gave that, it lights everything up so you can see, better where this might be at. So knowing that this has dye associated with it, you would want to make sure this person is able to take that dye, that it's not going to cause them trouble. All right, so possible complications you could have: urosepsis, obstruction, hydronephrosis, damage to the nephrons, and infection. So basically what we do for treatment, we want to control their pain because this is really painful to have a kidney stone. So we're probably going to give them opioids at first for the first 24 to 36 hours of acute onset. This is for really moderate to severe pain. We're going to hold the opioids if the respirations are less than 12, right? You could also get away with giving something like Ketorolac, which is Toradol. This is used to treat mild to moderate pain, or people that might have a fever or inflammation. So you want to watch for bleeding when you give someone that, because that's an adverse effect, and it could cause things like gastric ulcers. So there's also some other meds that you might see given. So spasmodic things like oxybutynin. This helps to decrease bladder spasms because of the renal calculi. So that's a really good med to give. This one, you want to know to not give it if this person has glaucoma, because it's going to increase intraocular pressure. And so it has some anticholinergic effects to it as well. So it could cause things like urinary retention, dry mouth, and constipation. So you would want to watch for those things. Anyway, I didn't even, let me go back a second. Other things on here, we want to push fluids. So lots of, like 3 to 4 liters a day if you can get away with it. You're going to watch their intake and output really closely, and you want to strain their urine, because if you can see that they pass it, you're going to be able to show this to the physician, and then you can get it tested to see what type of stone it is, and then that way you can best plan their future care, to get them to not have this happen again. All right, and then this talks about lithotripsy. So there are a couple of different types of lithotripsy that they could do. There is like an internal and an external one. So the external one, they lay on this mat, and this mat will deliver shock waves through their skin to their body, and the shock waves hopefully will break up the kidney stones. And then the internal one, they actually do it inside. So they're right there by the kidney, so they could do it there. Maybe that would be more effective in certain kinds, I don't know. Other things that you might see them do, there's certain surgical interventions. There's stenting that they could do. They could put a stent in, maybe their ureter if there's a problem there. Sometimes you'll see people get, what am I trying to say? You'll see people do like a percutaneous procedure where they may end up with nephrostomy tubes. So you may see urine being diverted into those nephrostomy tubes for a little while until they can take those out. So that's like a temporary thing. So anyway, what I do want to say about lithotripsy, this requires conscious sedation, and they have to be monitored during the procedure. They can have some bruising afterwards. That's normal at the site. And they can have some hematuria post-procedure, so that's something to be expected. All right, and then this just talks about some education things, which you guys can read through that. All right, thanks for staying, you guys. I will, I'll probably just record the other stuff. Don't forget that on Canvas, I have those picture things that I used to give you guys all the time in class. So those are kind of helpful, I think, sometimes. So don't forget about those. They're like this, So you can always print those out if you want to.
I have a question.
Yeah.
For the kidney part, so a lot of that stuff, like the medications and the blood transfusions and stuff during the treatments, is that the stuff that we got to pay attention to be on the test or on a test? Because I just am trying to figure out how I can like retrain my brain for this chapter, because it's not like this anymore.
Well, honestly, Ashley, you should not have any trouble at all with this chapter because this is your expertise, So,
I know, but we don't do that stuff anymore.
What's that?
We don't do this stuff that you were saying.
No, you're overthinking it. Okay. It's fine. We'll talk, you and I together. Okay. We'll talk about it.
I'm like, oh my god. Okay.
Yeah, you'll be fine.
Okay. Thanks.
All right, you guys, I'm gonna get off here. I know the weather's bad and everything. A ton of people left, so you guys have a good rest of the afternoon, okay?
All right, you too.
Thanks. Bye.
Thanks. Bye.